Welcome back to our first annual virtual meeting of the US Deprescribing Research Network. For those who weren't joining from the first part, I'm Mike Steinman, along with Cynthia Boyd. I am co-principal investigator of the network, and it is my pleasure to introduce our next two speakers, Kristin Zimmerman and Amy Linsky, who are talking about updates in deprescribing research. Just for me, it's a brief introduction. Amy is an assistant professor at Boston University in the Division of General Internal Medicine at the university, and especially at the Boston VA, where she is the co-director of the Medication Optimization Program in the Boston VA Center for Healthcare Organization Implementation Research. In addition to that very long title, she's done a lot of great work around studies on patient and clinician attitudes towards deprescribing. She has a large VA grant investigating that, and she's a practicing internist in the VA primary care clinic. And our second fabulous speaker, Kristin Zimmerman, is an associate professor in the Virginia Commonwealth University School of Pharmacy. And she has published a number of studies on and pieces on interprofessional care and medication use in deprescribing in older adults. She's a Congressional Health Policy Fellow. And clinically, as a pharmacist, she works in an interprofessional team caring for clinically complex older adults in the VCU Center for Advanced Health Management. In addition to Amy and Kristin, at the end of the talk, we are really pleased to have as a discussant, Catherine Sarkeesian. Catherine's a professor of medicine and geriatrics at UCLA and is a co-leader of our stakeholder engagement core. And finally, before turning the reins over to Amy and Kristin, just a quick note. During the breakout sessions, a number of people asked for sharing of emails because they wanted to stay in touch. And what we will be asking is, if you do not want your email shared, please email us at admin@deprescribingresearch.org. That's our main contact email, which can be easily found on the website. So again, if you do not want your email shared as part of a group attendee list, please email us at admin@deprescribingresearch.org. Otherwise, we'd love to be in touch. Amy and Kristin, thank you so much for joining us, and take it away.
Excellent. Thanks so much, Mike, for that introduction. Kristin and I are really excited about being here today. We had a lot of fun, maybe too much fun, putting this together. Could have created a really good bloopers reel. So hopefully it will be both entertaining and educational as we talk about updates in deprescribing research, not a trivial pursuit. No conflicts of interest for either of us. Standard disclosure, these are our views, not necessarily those of the Department of VA. So today, our objectives are to highlight some novel deprescribing literature from the past not quite 2 years. We picked studies in an incredibly unscientific way based on what is of interest to us. But based on some of the comments in the chat box earlier today, seems like it'll hopefully be of interest to many of the people on this conference. We also want to discuss key findings and implications and identify gaps in knowledge and needs for future research. And importantly, we want to have some fun. So to do that, we are going to take an interdisciplinary approach. Kristin's a pharmacist, I'm a physician, and move our potentially frail older man through this game board to try to get to the end winning piece of medicine being deprescribed. All right, so let's see where I land first. We want to begin just by setting the stage and getting a sense of what is happening in clinical practice these days. So to begin, we will present a trio of articles looking at de-intensification in long-term care. These are all by the same group of authors, looking at diabetes medicines, statins, and antihypertensive medications in long-term care settings. More specifically, they wanted to determine the incidence and the predictors of de-intensification using multivariable competing risk survival analyses. These are all older adults admitted to US Veterans Affairs Community Living Centers, essentially nursing homes. But probably the interesting here to see on that table is the differences between the three studies. So the first row that you can see is really how this idea of potential overtreatment was defined. So for the diabetes cohort, it was a threshold of the hemoglobin A1C less than 7.5 and on at least one diabetes medicine. For the cholesterol meds, this was looking at secondary prevention. So statins for secondary prevention, meaning that the patients had to have a history of heart disease, a stroke, or diabetes. And for the hypertension study, it was a relatively stricter blood pressure threshold of a systolic less than 120 and taking at least one blood pressure medication. For all of the studies, de-intensification used 7 or 14 contiguous days where the medicine was reduced in dose or completely stopped, and then looking at either 30 or 90-day follow-up. So what did they find? So in the top row, what you can see is that even though there's a relatively larger portions of patients who might have been potentially overtreated, less than half of the patients in each of the studies had deprescribing or de-intensification, with 46% in the diabetes cohort, 31% in the lipids cohort, and 41% with looking at the antihypertension medicines. Now, of note, though, there were some factors that were identified that were associated with either increased or decreased de-intensification. Many of these really pertain to the medication regimen itself. So for diabetes, sulfonylureas were more likely to be discontinued or de-intensified versus basal insulin. Also, the potential degree of overtreatment seemed to play a role. So for, again, in that diabetes study, patients with a relatively higher A1C, again, we're talking relative here, 7 to 7.5, compared to a hemoglobin A1C of 6 or lower, those with a higher A1C were less likely to have de-intensification. Similarly, in the hypertension study, patients with a very low systolic blood pressure on multiple medicines were more likely to have de-intensification. And so what we can see from these studies is that there is definitely some room for improvement, but we are making some strides. And it appears that those scenarios where the risk-benefit ratio is really much more obvious to clinicians, that those are the patients for whom de-intensification is already happening. And so then I guess the question is, how do we try to figure out more of these patients to make it more obvious for that clinical decision-making?
So kind of to tackle your point, I really like how this evaluation looks at the factors associated with like enhanced de-intensification and reduced de-intensification. But as you kind of pointed out, they're really medication and patient related. And the piece that's sort of missing from that for me is sort of what is the clinician thinking? And is that sort of a piece of the puzzle that results in sort of the lower than anticipated rate of, deprescribing in these potentially eligible patients? So that's kind of the missing piece for me on this one. And so let's see where I take us next on our journey. And it looks like we're going to stay in the cardiovascular med theme, but we're going to pivot a little bit and shift exactly towards my great foreshadowing here and segue into thinking about physician perspectives. And so certainly, when we think about provider perspectives about deprescribing, that's not necessarily something new, right? We've seen that there's a lot of evaluations that have been conducted already of provider perspectives, whether that's physicians, whether that's pharmacists, whether that's nurses, whether that's primary care providers or geriatricians. But this study I find really interesting. They took a bit of a different tack, and they're looking specifically at deprescribing of cardiovascular medications. And they're comparing the behaviors and attitudes of geriatricians to those of general internists to sort of cardiologists, or shall we say kind of the specialists in this scenario. And they characterized not just deprescribing practices in the past month, but perceptions about barriers and enablers and theoretic sort of deprescribing selections that these providers would make in a hypothetical case scenario for a multimorbid older woman. Over 80% of respondents had considered deprescribing a cardiovascular med in the past month, but only 40 to about 55% of respondents had reported that they've engaged with another clinician in regards to deprescribing a cardiovascular med in the past month, with internists and cardiologists being least likely to engage with another clinician about deprescribing. And geriatricians reported that they more likely connected with another provider about deprescribing these meds in the context of concern about limited benefit for that cardiovascular medication, given an individual patient's limited lifespan. So we'll see that theme kind of continue. Adverse reactions were a common and commonly shared facilitator or enabler of deprescribing amongst each of these three specialties. Some notable differences, though, with regards to the perception of geriatricians regarding enablers. Geriatricians were more likely to report that limited benefit for a medicine versus limited lifespan for an individual patient, or concerns about cognition and medication management would be potential enablers or facilitators, versus, let's say, cardiologists were more likely to report that medication cost was a potential enabler of deprescribing those cardiovascular meds. In all of the deprescribing scenarios that we sort of alluded to a bit earlier, geriatricians more frequently reported that they would deprescribe cardiovascular meds than internists and cardiologists. And this difference was perhaps most notable in scenarios that involved the patient demonstrating some kind of symptom that was, likely related to a medication-related ADR for those cardiovascular meds. So something like, being orthostatic or lightheaded that caused a fall, or in scenarios where the patient case sort of demonstrated that there might be some clue that there's some limited sort of life expectancy happening there. From the barriers perspective, cardiologists were least likely to report that concerns about interfering with other physicians or patient reluctance about deprescribing would be potential barriers to deprescribing these cardiovascular medications. And internists and cardiologists were more likely to report that there was insufficient evidence potentially of deprescribing benefits, so some foreshadowing perhaps for things to come, or that they had limited formal training on deprescribing. And so I think for me, this study is probably one of the neatest, in my opinion, but it's really cool because we know that healthcare is really complex, delivery is really complex. There's all kinds of different members of the healthcare team and different specialists involved in providing clinical care and making these deprescribing decisions. And so this study for me is sort of showing that there's some, important differences between how specialists might perceive their roles or their expertise or level of ownership over certain medications might be perceived, or if there are, subtle differences in training that sort of, might lead to some of these differences. And those things I think are worth exploring if we sort of harken back to Kara's talk earlier, thinking about you can have the most effective intervention, but if you don't have that buy-in piece, and I wonder if some of these themes might be worth exploring to try to figure out that sort of buy-in piece.
I mean, Kristin, all that totally rings true to me, working in primary care and co-managing lots of patients with a lot of subspecialists, wondering whether it's within my purview to make that deprescribing decision, and also thinking about it from my patient's perspective, who do they trust more to manage that medication? So really, how do we get all of us onto the same page as clinicians? And one of those pieces might be a matter of trying to figure out what is the clinical evidence. We were talking about that paper that's been put out, that we need that evidence to support these decisions. Let's see, where do I go next? All right, speaking of evidence, so let's think about the clinical aspects of things. Several of the breakout groups are thinking about trials, and so we want to present a trial, the optimized randomized clinical trial, and see whether that will provide some clinical arguments that can get all of the specialists onto the same page. So this study wanted to evaluate antihypertensive med reduction and then subsequent changes in systolic blood pressure and adverse events during a 12-week follow-up. It was a randomized, unblinded, non-inferiority study. The population of interest were adults aged 80 and over. And in this case, compared to the studies I was presenting earlier, the systolic threshold was looking at less than 150. All patients were receiving 2 or more blood pressure medicines. And the intervention was to deprescribe a single antihypertensive medication versus usual care. And then the primary outcome looked at maintenance of blood pressure control, again, using that threshold of less than 150 systolic at 12 weeks follow-up. So what did they find? So to orient you to this, there are 2 sets of analyses here. The top 2 rows are the primary analysis, which is the intent to treat. The secondary analysis, which is the per protocol analysis, are on the second 2 rows. And the main difference being is that 80 individuals were excluded from the primary analyses, 66 of whom restarted their medication. However, looking at the adjusted results for both sets of analyses, we can see the adjusted relative risk of maintaining blood pressure control at 12 weeks follow-up was 0.98, which was well within the non-inferiority margin set at 0.9. Now you might say, okay, great, so the blood pressure stayed less than 150, but how much did it go up? Did they creep up just a little bit, or did they kind of come really close to that 150 borderline? And so here again, we show both sets of results, both the per protocol and the intent to treat, which are on top. And the systolic blood pressure went up by basically 3.4 to 4.9 points. So not a huge difference, although as we mentioned, this was a 12-week time frame. So this at least is the beginning of providing some of that clinical evidence that not only are we able to safely deprescribe, but it's also in the absence then of subsequent adverse drug withdrawal events. And this type of information, more of these trials might be necessary for moving deprescribing research, moving the field of deprescribing forward.
So good clinical evidence to add into kind of our arsenal of trying to, get people onto our deprescribing train. Amy always makes fun of me when I call it the deprescribing train, by the way. But clinical evidence isn't always enough to change how we practice, right? Or to change our behaviors, particularly around deprescribing. There are a lot of inputs or a lot of pieces of the puzzle that can be used to kind of change practice and change our behavior. And I think clinical evidence is just one of them. So hopefully we'll foreshadow here, uncover some more of those sort of compelling arguments in our next segment as we move on to section 4. So drum roll, please. This is drilling home on a lot of the themes that came up earlier through Kara's talk and in the chat box and the discussion after that, and thinking about, is, money another compelling argument, the sort of economic evaluation of deprescribing to kind of get everybody onto that same page. And so I am going to largely assume that everybody on this call is familiar with the Deprescribe trial. Kara had referenced this trial as well earlier in her talk. Certainly community pharmacist-led, consumer-driven deprescribing intervention. This cost-effectiveness analysis is really focusing on benzodiazepines and Z drugs. And so this cost-utility analysis estimated the costs and the qualities associated with the intervention over a 1-year time horizon. And the research team used a 1-month cycle for moving between different healthcare states associated with utility, so insomnia benefit, and disutility, as you can see in the Markov model here, injurious fall, and related outcomes like fracture. And so they used this information to evaluate the incremental cost effectiveness ratio, as we'll see in a second, and examined a series of willingness to pay thresholds in different scenario analyses. So this is also a really fascinating piece. And very important, the researchers here found that this was the dominant strategy, resulting in not just incremental cost savings on the order of about $1,400 Canadian, but also incremental increases in qualities on the order of about 28 days. So that's some really compelling evidence right there towards at least deprescribing benzos and Z drugs in this type of intervention. And very importantly as well, this strategy remained dominant even if it required additional inputs. So let's say an additional, primary care visit or an increased fee for the pharmacist consult for that expert opinion, or also important, associated with varying deprescribing success rates. And so Kara mentioned earlier, right, that we know that this may be different with different classes of drugs where we see that there are different deprescribing success rates potentially associated. So I find this to be pretty interesting stuff. And in the same vein, sort of swimming into this sort of economic pool, the prior evaluation really shows, the cost effectiveness of a very specific deprescribing intervention. But as we mentioned, healthcare delivery is really complex. There's lots of different players, lots of different moving parts, lots of different disciplines. And what is the impact on deprescribing on some of those other parts of the healthcare system? And that's what our next study is going to sort of take us down the road. So this evaluation focuses on creating a clinical scenario for a theoretic typical older adult in Canada. And this research team applied a series of different deprescribing scenarios that obviously resulted in medication changes to the regimen. And they calculated both baseline and average change in costs to both the pharmacy margin, the government, or in this case, the publicly funded payer share, as well as the patient share in terms of cost. And so in pretty much all scenarios, the pharmacy margin in this sort of traditional sort of dispensing model did lose money. And that's in contrast to the publicly funded payer or the patient largely saving money. And so for me, this study really highlights the sort of unique, financial disincentive that pharmacies face in this traditional sort of dispensing pharmacy model. And, putting my pharmacist hat on. And this is especially interesting to me, given that the prior evaluation showed that even if we increase the pharmacist consult fee, for example, that deprescribing at least benzos and C drugs remained the dominant strategy. So I would be really curious to see if changes to remuneration for pharmacist services in this type of model might sort of offset some of those costs and sort of shift this balance a little bit. So I will take off my pharmacist hat.
One, I didn't realize you could take off your pharmacist hat, but I do really think it's interesting to see the differences in how the payment structures really impact the different players within healthcare. And especially fantastic to see that patients and systems all save money in these examples of the papers that we've just presented, especially given rising healthcare costs and such a concern that aspect can be both on the individual level and for health systems just overall. All right, let's see where I land next. Oh, bummer. Back to you, Kristin.
So if we're together in real life playing a game of Monopoly, our competitive nature would probably come out right now. But since we're playing as this sort of interdisciplinary team, thank you, Amy, for giving me the opportunity to move us into spot number 5 and shift the conversation a little bit. We've talked about the clinical benefits and sort of the optimized trial. We've talked about some of the economic data, but sort of drilling it down to a bit of a different level, wouldn't it also be really cool if we had some way for clinicians or for researchers to really efficiently identify which patients might be interested in participating in a discontinuation trial? And so that's what this next evaluation is going to examine. And so this research team evaluated the attitudes of men with lower urinary tract symptoms about deprescribing their alpha blocker, and also assessed willingness to participate in a planned discontinuation research trial. So the important term here is research trial. And so they found that, similar to what we've seen in some of the past sort of deprescribing attitudes of patients, right? Most patients were satisfied with their current therapy, but they were willing to stop if their doctor told them they could. About 93% of patients were willing to consider stopping. But when the conversation shifted, or the questions shifted towards participation in a clinical research trial for deprescribing, only about 61% of respondents indicated that they would participate in this research trial. So a bit of a drop from the 93 to 61, but being an optimist, glass half full, 2/3 isn't bad. Wouldn't it be great if we could sort of predict who those patients were? Who are those 2/3 of patients? And this evaluation found that folks who identified that they thought their alpha blocker therapy was more appropriate, or they had concerns about stopping, were less willing to participate in the research trial versus, let's say, respondents who reported that, if their doctor told them it was possible, they'd be willing to deprescribe, or if they had worse quality of life scores related to their lower urinary tract symptoms, those folks were more willing to participate in the discontinuation trial.
So that's all really interesting. I don't think of myself as a pessimist. So, great that 60% of those were interested in participating in a trial, but I'm really curious about what that voltage drop was from the 93% of individuals who were interested in stopping a medicine, but yet 32% of them, if I'm doing my math right, is just didn't want to be in the trial. Is it that when push comes to shove to focusing in on a specific medicine, they didn't want to stop it? Or is the reluctance more having to do with participating within research itself? All right, let's consider moving on to step 6. So speaking of research, as we've talked about research trials being, potentially really necessary from providing that clinical evidence, needing to have patients participating in it, what do health professionals and researchers think about conducting clinical deprescribing trials? So this study wanted to explore health professionals and researchers' perspectives, attitudes, barriers, enablers of conducting clinical deprescribing trials. This was done via a cross-sectional survey of international deprescribing organizations, along with targeted recruitment of published researchers. I would bet probably a week's salary that somebody on this call was recruited for that study and potentially even responded to it. So what did they find? So 96 respondents, 41% of whom had experience conducting trials. And the primary rationale said for why we need these trials was to optimize clinical and/or patient-centered outcomes. Some factors that were thought to be facilitators of conducting trials included the beliefs of other health professionals regarding the benefits of deprescribing, and importantly, the willingness of patients to participate. On the flip side, some of the barriers to conducting trials included the time and effort required. As anyone who has ever tried to launch an intervention study can attest to, it can be onerous. And then similarly, another barrier was establishing and maintaining relationships with other health professionals. Now, thinking more along this research continuum, as we were talking about earlier in the day, implementation science is just also going to be critically important. And so this study wanted to evaluate it, given that we know that there's this disconnect between the knowledge of what we discover, or what we know we should be doing, and what we actually do in clinical practice. So to understand this better, the authors wanted to determine the extent to which implementation factors were identified in deprescribing trials. And they did a narrative review looking at controlled trials or prospective cohort studies, looking at deprescribing, and they identified mentions of implementation factors. Now, I want to point out the distinction here is that the original articles didn't necessarily need to call these items out as implementation factors. That was assessed through this narrative review. And then those implementation factors were mapped to a construct according to the Consolidated Framework for Implementation Research, or CFR. So what did they find? They identified 548 abstracts, only 14 eligible articles, of which only 10 discussed implementation factors. There was roughly 1 to 4 factors per article, and the majority mapped onto the inner setting. And within that, the most common domain construct was networks and communication. And so what that is really identifying was the communication between the pharmacist and the other members of the care team. Many of the interventions that they assessed in their narrative review included these interdisciplinary medication reviews as the intervention. So it really does highlight the importance of communication.
All right. Well, thanks so much for sharing, Amy. I mean, I think these are really good, points that researchers and clinicians need to be cognizant of, and, be thinking about designing their trials with, this eye towards implementation science kind of from the get-go, from inception, sort of all the way through dissemination. And, if only we had a way to sort of get that word out to a group of deprescribing researchers, right? So cool. Well, thanks for the opportunity for me to bring this home today. We have covered a good number of studies in a very short period of time, and we have barely scratched the surface even of these trials. So Amy and I did want to distill down kind of what are the major take-home messages for each of the sort of game stops that we had made along the way today. And the first is that we aren't deprescribing enough in eligible patients, and reasons for that might be warranting exploration. There are differences that we've seen between medical specialties, and sort of exploring those to see how we might get on the same page is worthwhile. Clinical evidence might be one of those drivers that helps to put us on the same page. It makes economic sense, and perhaps more economic data might be one of the other tools that helps to move deprescribing forward. Patients are interested and willing largely to enroll in deprescribing related research trials, but we need to support researchers in doing that. And as researchers, being cognizant of implementation factors again throughout the continuum of conducting research. So with that, we thank you so much for this opportunity. We really look forward to answering some of the rich questions and comments that we saw pop up in the chat, and to speaking with our discussant today.
Thank you, Kristin and Amy, for an amazing talk. So before we get into Q&A, we have a sort of esteemed discussant, Catherine Sarkeesian. Jonathan, if you can spotlight Catherine, that would be great. Hey, Catherine. Love, Catherine, any kind of thoughts or reflections that you have to share based on what you've heard?
First of all, I just want to thank you so much, Kristin and Amy, for that really wonderful summary. That was a tall task that you were asked to do, and it was really great. I loved how you had a real combination of descriptive studies in the beginning. We saw your long-term care, just observational studies. One of the things that really jumped out to me is just the incredible untapped potential to move the needle so much farther. You highlighted a couple of landmark trials, the Deprescribe and Optimize, which is really exciting to see that we can move the needle in doing randomized trials. I was pleased that you chose the economic analysis, and it came up earlier in Dr. Tannenbaum's presentation that there's a lot of exciting opportunity to look at the economic analyses. And then finally, I like how the synergy that you put with the lack of implementation science. I'm going to ask one question, if I'm allowed to. You have a really great perspective having gone through all these studies. When you think about changing these horrible medications that we give our patients that don't help them, and you think of all the different areas where we can intervene at the patient, at the nursing home, at the caregiver, at the family, at the clinician, whether it's the geriatrician or the cardiologist, or at the system level, the payers. Where do you think we are going to get the biggest bang for our buck in terms, where should we really be focusing our efforts on trying to improve deprescribing in the future?
So I will say that my personal opinion on this is that it's going to come much more from system level, policy level, bigger picture aspects. We've been doing a lot of studies where we, focus on one particular medicine on one particular population of interest. But I think that if we want to really expand the scope of the impact, then it's going to have to come a bit more from top down.
Yeah, I mean, I agree with you, Amy. I think, though, it's also really difficult from the research perspective to conduct one of those sort of broad perspective trials. And I think it's historically been much easier to have that, bit of a narrow focus. And I think, there's a question in the chat about how come we're still short on evidence, even though we've evaluated some of this before. And I think that's part of the reason. It's really easy to kind of show in a research environment that sort of narrow focus. And I think sort of, Catherine, to your point about, where do we start? Where do we focus? I think the answer to that's really hard. We talked a lot earlier about sort of the economic piece, and I think that that's a really big driver. But I think in the US healthcare system, right, it's really hard. There's this disconnect between like who pays and who saves, right? And so with that system being so complex, it's sort of where is that driver? Even when you do have that economic data, like where does that fit in? And so for me, that's always sort of tough to sort out.
Thank you.
Fabulous. So I'm just going to share some sort of comments or questions from the chat and kind of throw out to the three of you for sort of comments. And this question was relayed by Ken Bookbar from the Starting and Research breakout. What search terms as you kind of prepare for this talk and your other work, have you found important to include in a review of the deprescribing literature? And I'll add one quick gloss on there, and especially given what Kara was saying in her talk about the importance of bringing in multiple disciplines and interdisciplinarity, how do we kind of wrap our hands around this research when there's not one specific PubMed term we can all rely on?
So I'll take sort of first pass at that. That was a huge, barrier. And how do we identify potential studies? We were really blessed with the fact that we weren't conducting, this large systematic review with a really long look back. We're looking at a very tight time frame where there's been a bit more consensus around terminology. But certainly, the spectrum spans everything from, deprescribe, deprescribing, discontinuation, polypharmacy. So there's a really broad breadth of terms that I think are important to consider including. And for this, certainly we had a bit of an advantage that folks conducting larger, systematic or narrative reviews might not have that sort of benefit of.
Yeah, I mean, I will echo that. And having done some systematic reviews in the past, the Boolean search logic is exhaustive at times. I think I saw something in the chat box earlier that one of the best things about the past decade is this convergence to the term deprescribing and having that, a more unifying term to make it easier to search out for those things. But there's absolutely so much different terminology out there right now.
Great. And another question that came up is, and you sort of touched on this earlier, but maybe can explore it more, is, given the number of studies that have been done, how come we're still short on evidence about the actual benefits of deprescribing on patient health outcomes? So why is that, and what can we do about it?
Yes, I'll take a first crack. I think part of it is the time horizon in terms of seeing the outcomes of interest, the clinical outcomes. It takes longer. A lot of the studies that we've seen publish on proxy measures, so things that are more process measures, perhaps looking at number of change in medications or whether or not the medicine was stopped and for how long, as opposed to the following out for much longer. Especially when you think about the rarity which some of these adverse effects will happen. I think the other difficulty is, especially when we look at older populations, it's not a straightforward, simple population. And so therefore it's hard to necessarily adjudicate whether those adverse events are related to the medication withdrawal. What is the causative issue there? And so I think that makes it much more complex to tease apart.
Yeah, I mean, that's an issue inherent when you're studying any type of sort of complex system or complex intervention, right? There's the sort of outcome related concerns, the population related concerns, the heterogeneity of the population as well. I think that the complexity makes it really hard to study. And I think that also the fact that every scenario is so different. We try really hard, right, in research to put everybody in these nice, tight-fitting boxes because that's what we have to do to see if there's an effect. But in real life, patients don't always fit into those really nice, tight little boxes as well. And so what really makes the most impactful difference for one patient may be different than what makes the most impactful difference for another patient.
I think those are great points. And can I just add one other point? Having been, as a clinical geriatrician and as a researcher who's been very interested in trying to do less, way before I knew there was a word called de-implementation, I think we're up against a bigger cultural issue of people who go into medicine and people who go into pharmacy and people who run hospitals that we want to do things. We want to go in and do something. We're not even taught in medical school the concept of watchful waiting, right? That's not even something that comes up. We do things, we order tests, we do procedures, we write prescriptions. It's just not part of our culture. And the people who go into medicine are probably more likely to be the people who want to do things. And so it's such a big culture change. It's probably many of you know, Ioannidis, I think, has done some really great writing on this topic about how we have such a low bar to get things approved to start new medications. If we just even raise that bar a little bit, it would be easier to stop doing things because we'd have fewer harmful medications to stop. Once we know a test comes out that shows it doesn't work, it's so much harder to get people to stop taking it than it is to start in the first place. I'm not sure how you fix that culture change, but it's something we're really up against.
That's maybe a good segue to the next question about caffeine earlier in their training before those kind of cultures are established. And can you sort of comment on the state of the literature about sort of teaching about deprescribing earlier in the educational process, for example, for students or residents in the medical field, or kind of equivalent for pharmacy and other fields, and what sort of educational interventions have been out there, and to the extent to which they've been identified as actually sort of changing practices?
Yeah, so
you may not know that offhand, so it's okay.
Yeah, and I think we sort of passed, and we had a long discussion about whether we had wanted to include sort of education-based evaluations in the talk today. And as folks have mentioned, when we look at the field of deprescribing research, it's hugely broad, right? It spans all of these different sort of levers, and education is a huge piece of that. In the context of sort of everything, we purposely sort of left that out a little bit today, but there has been some evaluations, and we could take a lot of time to talk about this, but essentially, we know that there are some interesting differences between some of the different sort of learner disciplines. We know that, we're seeing this greater push for interprofessional education and interprofessional learning much earlier in the continuum. We're seeing that there's a greater emphasis on sort of the continuum of prescribing again, and not just thinking of it as this sort of, one and done forever and ever perspective. So I would say that I think that that's a piece of deprescribing research that is still pretty ripe for the pickings, and also has some pretty valuable themes. Do you have other thoughts to share, Amy, that I missed?
Yeah.
I mean, I think you definitely covered it with respect to what we included, just more anecdotally, like, I think that it exists. From my own training, right? Like, I think you see it more in geriatrics, but I don't know how much you're seeing it in primary care or in any of the subspecialty rotations. I can't speak for necessarily the training outside of the medical field specifically, but I think it's gained more popularity. I've seen more, advertisements for grand rounds talking about this, or resident teaching programs talking about this. So I think it's different than it was 10 years ago, 15 years ago. And so there is an increase in interest of this being part of a curriculum. As to the evidence behind the modality and the best way of actually getting that information across, I don't know if that's out there or not yet.
Yeah, I mean, you bring up a great point. Like, when I think about trainee interviews for sort of that postgraduate training, we just had interviews for our geriatric medicine fellows over the past couple of weeks. And literally it came up in almost every single interview that we had with the geriatric medicine fellows. But again, that's geriatric medicine. And I don't know sort of how that might be different if it were, some type of specialist training program, if that would even be something that's on the table. But I do think the fact that that comes up so much more frequently, gives us some insight that at least in the sort of, professional training program perspective, we're doing something to at least put this on people's radar, perhaps more so than we were, a decade or more ago.
Yeah, it's going to be interesting to see like Dell Medical School and some of these schools that really, these new Kaiser, we have medical school here started by Kaiser that's really trying to start from the ground up and implement these ideas of only do things that work as opposed to do the things the way we've always done it, which is, a lot of places, the cardiologists that seem to have a disproportionate say in the curriculum, in my experience. We need geriatricians to write the curriculum and pharmacists.
and aging friendly people from across the spectrum.
Yeah.
Great. Super. One other question that maybe is sort of maybe a meta question, but sort of struck me as you were talking is that, there's a lot of these different types of deprescribing literature. And a lot of the studies that you chose to focus on were dealing with these kind of larger issue themes about things related to the PharmD model that Kara was talking about, the economic incentives, the attitudes, and fewer about things like the optimized trial about if you stop a drug, what's the clinical outcome, or the intermediate outcome. I'm curious, like, as you went through the literature, so what about those things spoke to you, and choosing to highlight the studies that you did, and what do you think that those decisions that you made sort of, what does that reflect, and what you think is most important is that people focus on as we move ahead?
So we did a pretty lengthy process of thinking through this. It's pseudoscientific. We wanted to try to identify papers that were newer information that might be incredibly beneficial for people to know about from all the different perspectives that we did try to touch upon. So if we found multiple papers within one realm, we often picked just one or two of them. The other, what I think was really interesting is we didn't find that many trials published, at least in the past year, right? So we know that there's others out there, but we were really trying to focus it based on the time frame. And I'm also really curious how much of this is a publishing bias issue, right? So we all know that negative studies don't get published. And so as we talked about, it's really hard to tease apart some of those clinical outcomes, some of those more meaningful outcomes. And if we're not finding those in our studies, are they not getting published? And so how much of that is leading to the information that is being disseminated?
Yeah, I would echo thoughts, Amy, in that it was really, there was a lot of debate back and forth about sort of which studies to include and which studies to not include. And it's really hard to sort of narrow down those that you think are most salient to the audience of interprofessional researchers of all different specialties, of all different disciplines, right? Of all different levels of research experience, and what are the themes that might be common in all of those. And I think that's what we tried to do. But interestingly, following sort of Kara's talk, Amy and I were sort of chatting in the chat earlier, and we find that so many of these studies are falling into that sort of orange and gray box of kind of personalities, which was also, I think, pretty interesting.
Wonderful. Well, I know we're sort of at the top of the hour. Thank you so much, Kristin and Amy and Catherine, for those really insightful comments. I'm sorry, there's a lot of other things going on in the chat that we don't have a time to get to, but thank you so much. And this is a great conversation to continue among all of us as we move into the future.
Absolutely. Thanks, Mike.
Thank you. Bye.